All right, and we're back again. We're going to keep rolling. Bring it on, bring it on, bring it on. And we're going to go right into tachycardic treatment. The tachycardic treatment that this is going to cover is a little bit more in depth than what we talked about with bradycardia, whereas we're only really getting aggressive with bradycardia if they have symptoms with it. Tachycardia is anything that's greater than 150. I don't care if it's narrow or wide, and I don't care if it has symptoms or it doesn't have symptoms. The human heart does not do well beating at rates in excess of 150 for very long. So there's going to be an intervention that you'll see as we cover this algorithm for all narrow complex tachycardias greater than 150, whether it has symptoms or not, and all wide complex tachycardias greater than 150, whether it has symptoms or not. The common thread that you're going to see between the two is that greater than 150, narrow or wide, you're giving a medication. I'm sorry. Greater than 150, narrow or wide, that does not have symptoms, you're going to start with medication. Uh, Tachycardia greater than 150, narrow or wide, with symptoms, we're riding the lightning. We're going straight to electrical intervention. And I'm going to talk about that here in a second. So let me get switched over to my other view here. Let's get out of the vortex here. And there we go. Tachycardic algorithm. Now let's visit my buddy, the 12 lead trainer here real quick. And we're going to look at, so SBT. Now that's pretty fast. I mean, it doesn't have to be that fast. Let's have some nice happy trees here. Yeah, there we go. 180. Narrow complex tachycardia greater than 150. Again, SVT or supraventricular tachycardia is the umbrella for sinus tachycardias, atrial tachycardias, and junctional tachycardias. Because again, it's beating so fast that it's really, really hard to see what's going on in between those QRS complexes. However, you can definitely, uh, excuse me, you can definitely tell that it's a narrow QRS complex. That's about the only thing you can measure, that and the rate on a 6-second strip. Excuse me. So let's get into our treatment here. We are doing all of our initial stuff here. Let's see. Let's make sure this is nice and again, this will be listed in what would course materials, something like that. I'll put a little announcement of where I ended up hiding these little buggers. This will be under adult tachycardia algorithm. So greater than or equal to 150 tachyarrhythmia. We are assuring all of our ABCs are good. If this person has a SpO2 of less than 95%, we are giving them oxygen, titrating between 95 and 99%. We're applying a cardiac monitor. We're getting a 12 lead if possible. However, a 12 lead on someone with a heart rate that fast is probably not going to tell you anything other than 12 different leads of a really, really fast rhythm. But again, best practice whenever we have arrhythmia is to get a 12 lead on. Get some sort of venous access because we are going to use it here, folks. Now, same rules apply to bradycardia as far as the rate is problem number one. We're only looking for an additional problem of these 5 symptoms: hypotension, acutely altered mental status, signs of shock, that's catecholamine release, that's a shunting of blood from the periphery to the core. So pale, cool, diaphoretic skin. Ischemic chest discomfort, we know what that is. And then acute heart failure. Again, that is the person who just recently started having fluid in their lungs or peripheral edema. That's are your legs usually this swollen? No, that just happened a few hours ago. Okay, that would be signs of acute heart failure. So let's say they have none of these symptoms. All right, we're going to keep it simple here. just the problem of tachycardia greater than 150. In this case, we're saying it's a narrow tachycardia greater than 150. So the answer is no. Again, doesn't matter if they are stable or unstable. We have to intervene. And as I said before, narrow complex tachycardia greater than 150 without symptoms is a pharmaceutical intervention. And that pharmaceutical intervention is adenosine, also known as Adenocard. Now, there's going to be two different schools of thought on your dosing of Adenocard. You're always giving it twice, possibly. And then what you're going to see is the differentiation of dosing with that. Adenocard has a very short half-life in the blood. So it needs to be given in the most proximal IV site that you can get on an upper extremity. It is rapidly pushed. It is followed up with a normal saline flush, 10 to 20 mLs, rapidly. Then you flow your bag wide open. You always need to record an EKG tracing. And what Adenocard does, or adenosine does, is once it hits the heart, it inhibits the SA node down through the AV node. It causes a slowing down and even a brief period of asystole on the heart. The only difference, ACLS says 6 milligrams followed by 12 milligrams if your initial 6 did not work. Many Franklin County protocols, you're going to see 12 followed by 12. That's a medical director thing. Personally, I see 6 work. I've seen 6 work more than I've seen it not work. It's just, but other people, again, with more experience than I do, have seen 12 work more effectively than 6. As far as ACLS goes, initial dose 6 milligrams, followed by a rapid flush, then open your bag wide open, and then watch your monitor. As your rhythm slows, and we'll take a look at what that's going to look like, come back to our 12 lead trainer. If you look at this EKG tracing up here, you're going to see it get slower, 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 slower. It may even be a flat line or just a very, very bradycardic rhythm like this. And then ideally, you'd see it convert at that point in time. So you would convert that SVT into whatever the underlying rhythm was. Some rhythms like AFib, aflutter are rarely converted by just straight up adenosine. And the way that you would know if you're dealing with AFib or aflutter is you push adenosine, that rhythm slows down to a point where you can print it out during the slowdown, and you can note what that underlying rhythm would be. Here we note the underlying is a normal sinus rhythm. Let's throw a AFib on here. Okay, let's ratchet that beat. Let's ratchet up that rate. Okay, so you notice that AFib, one of the common description of the regularity is that it's irregularly irregular. Well, if you're looking at this running EKG rhythm here, I can't decipher any irregularity in that because it's beating so very fast. Giving adenosine, you're going to see it slow down, slow down, slow down, but it's not going to convert it, so it's probably going to go right back up to an RVR. However, we had the opportunity to snapshot it when it was slower and confirm that it was an underlying AFib. And I'll talk to you about the drug that's going to be involved with that when it's stable. Again, adenosine followed 6 milligrams followed by 12. If that doesn't work, what does it say to look at? Consider an antiarrhythmic infusion if you have it, and then seek expert consultation. All right. The antiarrhythmic infusion that we are discussing would be something called cardiazem. Right. Cardiazem, far more effective on those AFib with RVR SVTs, and then very effective on any other narrow complex tachycardia that does not respond appropriately to the adenosine administration after you've tried it twice. A big thing that you're going to see here that is an old habit that's dying hard, and it's taken 20 years for this thing to finally die, and I still hear it come up, folks, is that a person who doesn't respond to stable treatment automatically gets appropriate for uh, unstable treatment, and that's just not true. It's just not true at all. Okay. Um, so that's what we're going to do with that. Let's come back to wide complex tachycardia. Okay. Uh, so we need to look at a ventricular tachycardia. That's really the only wide complex tachycardia that you're going to see, greater than 150. Again, this is a tricky bugger because it can be stable, it can be unstable, and then it can also be pulseless. And there's a different way to treat it for all three of those things. Let's start with the stable one. This person, through some, I don't know why they would be, because I don't think I've ever seen someone who was not symptomatic severely in a ventricular tachycardia. Uh, Children, I think I saw a kid once that wasn't, and that was a congenital thing. So if you are going to go the wide complex tachycardia, but we did not have any symptoms still, okay? So it's just, I felt a fluttering in my chest, okay? I just feel my heart beating really, really fast. I don't have low blood pressure. I don't have altered mental status. I don't have signs of shock. I don't have chest pain. And I don't have signs of acute heart failure. Uh, Adenosine is an option for you, but really the first thing that you need to go to is an infusion of amiodarone. Amiodarone is diluted in a 100 bag, the smallest bag that you have, 150 milligrams in 100 mLs of fluid, and then you are going to infuse that over 10 minutes as you see here listed. That is the stable treatment for wide complex tachycardia. There are other things that you can do. There's lidocaine drips. I don't really want to broach on that because amiodarone's the number one thing that's mentioned. Procainamide, there's one time that I'm going to have you study procainamide, and it's not just yet. So don't worry about that. And then Sotalol is a beta blocker that you're going to see in more of an in-hospital or critical care medic thing. So bonus, you don't have to worry about that amongst all the other things that you got to worry about. So stable treatment for narrow complex is adenosine. You could look at a calcium channel blocker and then seek expert consultation. Stable treatment for a wide complex is, if you're not sure if it's wide, you can try adenosine, but it should stick out to you pretty well. And then if you can confirm that it's wide, you need to go to an amiodarone infusion over 10 minutes. You see this here, the term vagal maneuvers, and that's something that I don't even want to describe it for you at this point in time. But that's plan A with a very, very quick follow-up of plan B, because vagal maneuvers aren't as effective. They work on a small percent of people, so you don't get to the pharmaceutical part. But you're having them bear down through various ways to put pressure on the vagus nerve, which is going to, in effect, slow the heart rate. We'll talk about that once we meet in person here. So I talked about two different kinds of tachycardias. I talked about two different kinds of pharmaceutical treatments. Now let me make it easy for you. I have a person who has a tachycardia of greater than 150. So that's ventricular tachycardia or SVT. And this person is symptomatic. This person's mild to moderately sick, as in they have one or more of these symptoms here. It doesn't matter wide or narrow. The first move is always electrical intervention with the possibility of sedation if they are not so sick that you think they could make it to wait for that. Um, Synchronized cardioversion is similar to defibrillation, As a matter of fact, if you want to look at the technical terminology for each of those, synchronized cardioversion is where you hit a button on your uh, defibrillator monitor, and it picks out each underlying complex so that it can deliver joules that you preset directly onto one of those complexes to provide a electrical reset of the heart. Again, when people are stable, we're trying a pharmaceutical reset of that tachyarrhythmia. When people are unstable or symptomatic, we are going to the electrical reset option. Now, there are different energy settings for different commercially produced monitors. When we get into lab, I'm going to have your preceptors, and if not them, myself directly, talk to you about what the manufacturer recommendation for synchronized cardioversion is per all the three major monitors that are out there. So I'm not gonna tie up the bandwidth with that case. You are going to reassess the rhythm after you perform a synchronized cardioversion, and hopefully you are going to see a conversion, a successful cardioversion of that tachyarrhythmia, hopefully into something like a sinus rhythm, something slower and less fatal than the tachyarrhythmia that they were in prior to that. And that's really all that you need to worry about for tachycardia. The only caveat to that is uh, looking at AFibs with RVR or A-flutters with RVR. And if you've been kind enough to take the time to watch these prior to class, or you were able to watch them on Tuesday after John was done with your clinical orientation, and then again, not going to cloud your head with some of these specialized considerations that you might do with some very specific rhythms. I am going to talk to you about them at some point because I know you're bright enough to take it into consideration. But at this point, you've all been real troopers, and I appreciate it. So I'm not going to drop anything overly heavy on you. Um, you can wipe the looks off your faces because I know you're acting like I've already dropped so much on you. But I know you're good for it, and we're going to get there by the end of this week. Again, this algorithm will be posted, if not already, is going to be posted to your Blackboard, and I will put a little notification on there of what folder it's actually in, along with this YouTube uploading. So now I need to figure out how to upload a video to YouTube. But I appreciate your time if you did take the time to watch this, and I look forward to seeing you on Wednesday. Enjoy the rest of whatever day this is that you watched it on.